Good evening, one and all. Welcome to the SKIP session 6, which is on a very important topic called the clear aligners. And we have a very eminent speaker of the day, Dr. Sarvaraj Kohli, who is the professor in the Department of Orthodontics in Hitkarni Dental College in Jabalpur, Madhya Pradesh. Okay, so first of all, I wholeheartedly welcome Dr. Sarvaraj Kohli to today's session. Next, I welcome all our dear students, the third years and final year part 1 students for this SKIP session 6, and also the coordinator for today's program, Dr. Rino Robek, and also our student coordinator, Steffi Sargent, to this program. Okay, so now I invite Steffi, our student coordinator, to give a description of our speaker of the day.
Thank you, sir. Once again, we welcome our speaker today, Dr. Sarvaraj Kohli. He graduated in dental surgery from SP Dental College, Varda, India, securing the highest marks in the subject of orthodontics, and attained his master's in the discipline of orthodontics and dentofacial orthopedics in 2010 from Savita Dental College and Hospital, Chennai. He underwent training in the Tweed Merrifield Directional Force Technology at Arizona, United States. He has published extensively in several international and national indexed journals of repute. He is currently serving on the faculty board in the specialty of orthodontics at Hitkarni Dental College and Hospital, Jabalpur, and is a consultant orthodontist and dental surgeon at Jabalpur Hospital and Research Center. Besides, he serves as the orthodontic coordinator for the craniofacial anomalies and cleft care unit at DSD Surgical Center. He's delivered lectures and conducted courses across India, Nepal, Bangladesh, Malaysia, Indonesia, Sri Lanka, Belgium, Egypt, Denmark, and Netherlands. He served as an executive committee member of the Indian Orthodontic Society for 4 terms and is the editor of Journal of Contemporary Orthodontics, the official publication of the Indian Orthodontic Society from 2021 to 2024. We welcome you, sir, to the session.
Thank you so much, Dr. Steffi. I hope I'm audible and visible. All my slides are visible. Is the first slide visible?
Yeah, Dr. Sarvaraj, yes, you're audible and the screen is also visible to us. You can start.
Excellent. So it's a chilly evening here in Jabalpur. Okay. Temperatures hovering between 16 to 18 degrees, and I'm sure it's quite warm in Kerala. And I would like to ask how everyone is on this wonderful evening on a Tuesday. And there was something which Dr. Bentley taught me. He said, whenever you meet anybody from Kerala, always say Endha Vishesham. And then you can speak in English, because then they understand that you know the lay of the land. So I hope everyone is sugam. And let us start with this topic. I'll be very quick. We'll be speaking about aligners, the why and the wherefore, or what you need to know as undergraduates. And this is a picture from today morning. So this is where we went cycling nearby, and it's quite misty and foggy, and it's pretty cold these days. So you are familiar with the various types of braces. They're metal, they're self-ligating, they're clear, self-ligating, and they're lingual appliances. But there's always a need to develop technology more so that we achieve better and more intelligible results with our appliances. So this is from a lecture by Dr. Baiti Melson, and she says that there are 3 things which have changed orthodontic care delivery. The first is the type of appliance being used. So we have seen a paradigm shift in our appliances from as undergraduates, you would read about fixed appliances, the components, and a little bit about the type of appliances. So we moved from standard edgewise. My apologies. So we've moved from standard edgewise appliances to straight wire appliances. You've also had been hearing, I'm sure in Kerala, a lot of orthodontists use anchorage with mini screws. So that's again something very interesting. And also what you see is a change in the distribution of patients being treated. So I have a 2nd generation practice. My dad's also an orthodontist. We work together. And we would see that earlier when I was a kid and I would come to the clinic, there would be about 80% children and 20% adults. And now we see that there are about 45% adults and 55% children seeking orthodontic care. And this is primarily because the awareness has improved, the paying capacity has improved, and also because orthodontics in conjunction with other disciplines like perio, prosto, oral surgery is helpful in giving us a better dental apparatus. So what are aligners? They are just a clear and clever alternative to traditional orthodontic appliances. And it's a series of trays that move the teeth a little by little. There has also been a change in orthodontics, as in we've moved from empirical mechanics to diagnostically derived mechanics, wherein we use CAD and CAM technologies, which is image capturing, 3D OB visualization, planning the entire treatment on a software, and then bringing it into motion in the patient's mouth, using monitoring tools like dedicated scanners, and also using high precision appliances, which are milled, or I could say made individually for the patient. So, well, it's not a new technology. I would rather say it's old wine in a new bottle. And the technology predates to 1966, when Shu et al. Proposed the first thermoforming machine. And tooth positioners or Counselling positioners were used a lot in America after treatment with fixed appliances was completed. And the clear aligners are practically an offshoot of that. So there are certain indications and contraindications which are there. Like if you have crowding greater than 6 millimeters, it is best left to a treatment with an orthodontist who has had sufficient experience. Be it a fixed appliance or be it a clear aligner, the treatment must always be done by an orthodontist, because the orthodontist has undergone 3 years of additional training in understanding how the teeth moves and again make it move more efficiently. Similarly, when we speak about spacing, from 0 to 3 millimeters is fairly simple to do, but anything greater than 6 millimeters is a little bit of a problem. Then midline alignments. So I'll show you in a case how this actually works when there is a Boltons discrepancy. And when you look at the overjet with a discrepancy of more than 4 millimeters, again, aligners have a certain amount of limitation and should be treated with care, similar for overbite and open bites. So the advantages with an aligner are that A, they are clear, they're easy to remove. It's basically a removable appliance. So they're generally very comfortable. There are lesser chances of white spot lesions or iatrogenic damage. There is little speech trouble. The patient takes about a week to get accustomed to speaking with them. There are no sharp edges or pointy edges that injure adjacent soft tissues. And if your patient has bruxism, it can also help with those who grind their teeth. The steps in treating a patient is the clinical examination and diagnosis, proper impression making, digitization, tooth segmentation, virtual treatment setup, a clinician approval, STL file fabrication, aligner manufacturing, and finally delivery. So when you talk about impressions, if you're making an impression, it should be a very, very detailed and accurate impression with all surfaces. Even the gingiva should be recorded extremely well. The attached gingiva especially should be recorded very, very well. The occlusal surfaces should be good. There should not be any kind of defect in the impression. It should be a perfect impression with defined and clear margins. Normally, the best impression material is a polyvinyl siloxane material, or a putty and a wash material, so that you can record it nicely. And the other option which you can use is you can use intraoral scanners by various companies. There you have to see how good the resolution of the scanner is and how fast it can scan an arch. Then you come to something known as attachments. So attachments work similarly to how brackets are positioned on the teeth. So the attachment protocol allows teeth attachments to be either active or passive. So passive attachments aid in retention and anchorage for intrusion, whereas active attachments are used for in rotation control of rounded teeth, extrusion, and for root correction. So here's a case where you can see this lady who presented with severe crowding in the mandibular arch and a little skewed maxillary arch and an increased overjet, and nothing about her bite was really good. So this is how we finished her with some amount of interproximal stripping to gain space. and we resolved her crowding, and we got her into a good bite. You see the overjet is also reduced now, and she has good class 1 canines and molars. So this is the initial scan of the patient. Here you can see these 2 blocks. So these are passive attachments which have been placed, and this is what we had predicted in the patient before planning the treatment. This is the superimposition of the maxillary and mandibular arch. You can see that we've also been able to achieve a certain kind of expansion in the premolar segments. This is the comparison between the pre and the post treatment. And this is what you see again. These are the attachments on place. This is another girl. This is not treated by me. This is by Dr. Sean Holiday, but this is using our aligner system. There's a lot of crowding in the mandibular arch and a certain amount of deep bite. We're not too happy with the way it is. So this is how the attachments are placed. What is interesting over here is that we have attachments on the buccal as well as the lingual surface of the mandibular canines. And this is what I was talking to you about, the individual tooth segmentation. So every tooth has to be individually segmented so that we can plan its actual position and then go on to fabricate the aligners. And this is the scan. And this is how it was after we took a scan in the patient's mouth. The impression was scanned, and this is how it appeared. And this is her at the end of treatment. The maxillary teeth have been pulled into place, and the mandibular teeth, especially the incisors, are now in a well-aligned arch. So if you look at the structure of the attachments, there could be ellipsoid, there could be vertical rectangle, there could be horizontal rectangle, there could be beveled attachments. So that depends on how you want to plan your case and which attachment works best. So some are good for rotation control. So some are good to create a couple. And by couple, I don't mean the couples we see in the college during lunchtime and after Dr. Benley leaves the college premises. So these couples are two equal and opposite, two forces equal in magnitude but opposite in direction, and they help in derotation of the teeth. So if you look at the evidence behind it, you see that clear aligners help in leveling and aligning the arches, and they are effective in controlling anterior intrusion, but not as much as anterior extrusion. And they are effective in controlling the posterior buccolingual inclination, but not the anterior buccolingual inclination. So here's another case, severe crowding. You can see collapsed maxillary arch, a little bit of an incomplete open bite with tooth number 2-1, crowding in the mandibular arch. And this is mid. This is the arch expansion and interproximal stripping. And this is how we finished him. We finished his teeth. You do see a little bit about amount of lack of very good interdigitation. And this is because normally the aligner must go on to the last erupted tooth. But sometimes a certain amount of it may be left because it's difficult to manufacture. And that allows that particular tooth to supra-erupt a little bit. And that causes this. But if we ask the patient to chew gum, chewing gum, any sugar-free chewing gum, and it just it settles into place after that. So here you can see the superimposition of the initial with the final. And you can see we were able to achieve 4 millimeters of expansion. And it wasn't as much as skeletal expansion as just dentroalveolar expansion, because the teeth were, like I said, very collapsed arches, and the bicuspids were placed palatally. And then we just had to allow a little bit of force to allow it to overcome the circumoral musculature pressure and then get the expansion we desired. You can also notice on the scan the extrusion of the upper lateral incisor, the upper centrals and the lateral, the upper left one. And here is the piece de resistance. You can see that all the teeth have been in place. The occlusal is of surfaces aligned well with pre and post. And if you see the gray images are the ones which is in post-treatment. So this is something I do routinely is as long as we didn't have a scanner, we would take impressions and scan and superimpose to see how much of movement did we actually affect when we used aligners. We got about in this case, we got about 4 millimeters in the maxillary arch, and we got about 2 millimeters of expansion in the mandibular arch. And these results were found in concordance with Grundheit, which was published in the Angle Orthodontist. So here's the initial and here's the final. You can see that the emergence of both the upper incisors is now similar, and we've got a nice bite. It's not a very open bite. It's not a deep bite. It's just perfect, just the way I want to leave the patient, and a little bit of gum to be chewed, a little bit of masticatory exercises, and all of this just it fits into place like a jigsaw puzzle. So let's look at this case now. This is a maxillary and mandibular diastema case. And this is how the patient was. You see these round buttons over here, and then you can see the beveled surface over here. These are the composite attachments, and we prefer to use any good quality flowable composite is excellent in this person. When you're looking at the periodontal health considerations, these are papers by Mietke in the German Journal for Orthodontics. And both these studies have compared the periodontal health of patients who underwent treatment with aligners to that of patients who underwent treatment with OB fixed appliances. And they said that there might be better periodontal health of patients with aligners because of possibly lesser amount of plaque retention as compared to fixed appliance. So let's look at a few cases. So this was a girl who wanted to be a model. She is a model now. And she had these buccally placed canines, especially the tooth number 1-3, and she wanted that to be pushed in. Otherwise, it was a fairly good arch with good restorations. She just wanted us to do the maxillary treatment. And here, if you see, this was the scan, this was initial, this was final, and the canine was pushed in. So here, if you see, we were able to pull in both the canines. You can see here, we did some amount of interproximal stripping, and we were able to push them inside. Also, the bicuspids, the segment was collapsed, so we also brought that in. And when she smiles now, she has a full smile. And there are no buccal corridors. There's a good amount of gingival display, very mild, but OB makes it look very, very youthful. Another case, she had a lot of restorations, and she had this midline diastema with a very thick frenal attachment. This was her Panorex. This is how we planned the treatment. You can see there are rectangular attachments in place. And this is a classic Bolton discrepancy where the upper incisors are small. So what we did was, after we corrected this, we knew we'd be left with space distal to the lateral incisors. So a buildup was planned for those teeth. Here, if you can see, this was final. This is during treatment. This is at the end of treatment. She has midlines on. The teeth fit well into their place, and there's a little bit of buildup done over here, though we told her to get a veneer done. And most cosmetic dentists would want to put veneers or crowns on all the front teeth. But the thing is that they would make the teeth very, very broad, especially the incisors being very broad and not very tall, long in height, give a very, very poor appearance when the patient smiles. It looked like the teeth of a cow or a buffalo. So it's always better to have the teeth small in size and reflecting beyond the shape of the patient. This is the Boltons discrepancy, which I just mentioned, that after we moved the teeth towards the midline, there was a little bit of space over here. And these can either be done with a canine buildup, which is preferably better than doing a buildup on the lateral incisor. Now, the next patient this was taken with a phone camera, so the quality of the image isn't very great. But she had a traumatic bite. The canines, if you can see them, were end-on, and there were proclined upper and lower incisors and a big midline diastema, and not the greatest of periodontal health. But this is at the end of treatment. All the teeth, they fit into their place. There's no diastema. We do have some amount of black triangles over here, but this was unavoidable. And there was a lot of gingival overgrowth over here. This was majorly because she did not maintain very good oral hygiene. So it's important that even with aligners, the oral hygiene is maintained nicely. Now, this is another case which we treated in about 7 months. If you notice carefully, she wanted to have, she was very happy with the way her teeth were, except that she wasn't too happy. She had a tooth to be replaced over here, and the molar was a little supra-erupted, so we had to correct that. And the lower 5 over here on the left side had drifted lingually, so that had to be corrected. So if you see carefully, the lower 5 over here, 3-5 was lingually drifted. And if you see over here now, we were able to intrude this a little bit enough so that the prosthodontist could we put a crown over here. And then we also brought 5 back into position and we closed the anterior spaces. Here, if you see the change that has taken place, this 3-5 is now in its correct position and the patient can bite very well with it. So this is the image pre and this is post. This is a movement overview. Whenever you plan treatment, you can see the amount in millimeters on how much tooth you are moving. And you get the rotation degrees as well as the axis and the teeth which you're planning to move. And where all space was required. Similarly, another case or a class 2 diff 2, we did we wanted to procline the upper teeth and then plan out for surgery for the mandibular arch. So we did a little bit of IPR, we got the teeth into the proper position. And this is how she was during treatment. The incisors in place and the teeth were made a little flatter and straighter. This is an interesting case because this lady had a crossbite on the right segment. She had spaces in the mandibular arch. And she obviously had a lot of crowding. So this was the mid record 1. And this was record 2. You can see the crossbite getting corrected now and the teeth are moving out. Then there was this case where there were spaces between the upper and lower incisors and the midline was always off, which is why it's very, very important. That's why I say time and again that a lot of companies, aligner companies will tell you that you don't need specialists to help in this. You just need to take an impression and we work with it, but that's not how it actually runs. You require a very deep understanding of how teeth move, what are Boltons discrepancies, how the teeth should be positioned at the end of treatment. And because even after we finished the treatment, this would settle, but we were still left with this midline not matching. And this was because the upper and the lower teeth were not matched with respect to each other. So a good thing to do in these kind of cases is that we reduce some tooth material. But if your patient's happy and the upper midline is not shifted as much, sometimes you just let go of it also. So things to watch for with an aligner case is that your case selection has to be very, very correct. Whatever aligner sheet material you use, whether it's polyethylene glycol or it's the newer advances, it's important. Patient compliance is very important. Your patient needs to wear your aligners for at least 22 hours a day. They just 2 hours to eat and brush their teeth. Otherwise, they should just keep it on all the time, even when they're sleeping. And patient counseling is very important. So patients have to be told what can be achieved, what cannot be achieved. And in some cases, if you feel that a fixed appliance can do a better job, then you have to tell them that, look, this might not give you the ideal result, and you might need to go for a fixed appliance. Attachments are made of composites, so yes, they can be broken. So you have to be very careful. And at every appointment, the patient comes, the attachment integrity has to be checked. It cannot be done in a manner that you give all the aligners to the patient and you tell them that, okay, this is it, now keep wearing it and show me at the end. Periodic recalls every 6 weeks or 8 weeks are very, very important. You have to check for aligner lag. Is the patient wearing it properly? And on a software, it's very important On a software, it's very easy to move the teeth wherever you want, but it doesn't really translate into clinical orthodontics. So again, you need to have very realistic treatment goals and be very firm on what can be done and what cannot be done. And whenever you get a virtual treatment setup, make sure you analyze it properly, and your orthodontist sees it, and only after a thorough evaluation should the aligners be printed. So it's very new. It's just like shifting from a cycle to driving a car. So it will appear a little different, but it's easy, and I would urge all of you to take up OB orthodontics at the postgraduate level, so that you are able to deliver on good quality treatment. And I was told to keep it very short for the undergraduates with a few case illustrations. So I think that is it. If we have any doubts, we can take them up.
Thank you, sir.
Yes, thank you very much, Dr. Sarvaraj. Okay, it was quite a good session for all of us, especially because the students were very much keen to know about clear aligners. Okay, so they have only heard about clear aligners. They never knew what exactly it is, because the textbook doesn't give in detail about the clear aligners. Yeah, so they were more keen to know about it, and you have given a very good presentation. So thank you very much. Dear students, if you do have any queries regarding clear aligners, please do post it. Okay, we'll take it up, and Steffi shall provide the questions for which Dr. Sarvaraj can answer them up.
Thank you, sir. Sir, we have a doubt.
Okay.
Sir, in case we have already started off with the metal braces, can we change to our clear aligner one midway?
Yes, you can change to the clear aligners midway. I mean, you'll have to debond the appliance, allow a little bit of relapse to occur because the teeth are obviously not in their most ideal position, and then make impressions and then start with the aligners.
Okay, sir. Thank you, sir.
Yeah, Dr. Sarvaraj, what is the charge for the clear aligners for the patients?
What are the
treatment charge for clear aligners?
That differs from place to place and the severity, because it depends on the number of trays that you will be printing for a patient. So I think it's a very clinic office specific question. What one office charges to what another office does.
Okay, what is the actual just minimal basic charge starts from what price, just for the students to get an idea about?
At my office, for a relatively mild case, we start at somewhere around 110,000, and then it goes up from that.
Okay, fine. This is just for the students to get an idea for. Yeah. Steffi, any more questions are there?
Yes, sir. Yeah. Sir, since it is bonded, sir, we cannot remove it while eating, right, sir? So how do we practice it while eating, sir?
No, the aligner is removable. The attachments are bonded. So attachments are like a composite restoration. They remain on the tooth.
Okay, sir.
But you advise the patient not to have extremely hard food that can cause them to break. If the attachment does break, then the patient should go back to the orthodontist to have them replaced. Because it's very important to have attachments. The case does not run well if no attachments are given.
Yeah, the aligners actually are removable at the time you want to eat food and all. You can
remove, you can remove
the aligners and then you can place it back. Yeah.
So one of the advantages of aligners is that you have no dietary restrictions, except for extremely hard food. Probably you can eat everything.
Yeah, Steffi, any more questions?
No, sir.
Okay. Now I would like to invite Dr. Rino Rupak, our staff coordinator, to propose the vote of thanks.
Good evening, everyone. It's my privilege to propose vote of thanks. On behalf of Department of Public Health Dentistry, I take this opportunity to express my gratitude to our renowned speaker, Dr. Sarvaraj Kohli, for his excellent presentation, which has enlightened our students. Thank you very much, sir. Now I would like to thank Dr. Bentley George, Vice Principal and Head of the Department, for his constant support. Also, I extend my gratitude to third years and final year part 1 students, and special thanks to Dr. Steffi Sajan, who is a coordinator. Thank you.
So once again, thank you very much, Dr. Sarvaraj. It was good to have you in our SKIP platform. Okay, it was good that you remembered the Malayalam which I had taught you. Great. So it was great fun to have you in our SKIP session. Thank you very much. Okay, so yeah, we'll be sending you the certificate and memento to your address. So
send me some carry me along with it, the certificate.
Good. Thank you very much. Yeah, so we'll wind up the session. Thank you very much. Yeah, have a great day.